Thank you so much for inviting me for this topic on weight loss management, choosing between medical and surgical managements. My sincere thanks to Dr. Sanjay Agarwal sir and Dr. Harshal Ekatpure for inviting and involving a surgeon who will be speaking about options when it comes to interventional options for weight loss. We all have heard now what are the different options when it comes to managing diabetes and obesity, and the trends have been changing, and the biggest shift in the trend is because of the COVID epidemic has led to creation of polarization. So people who were obese have become super obese, and people who were in the midway have made several attempts to lose good amount of weight. Now this has effectively led to polarization worsening in obese patients, and COVID itself has also contributed in increasing the problems of diabetes, the exact cause of which is still unknown. I don't want to go into the series of before and after pictures, but if we have to see an image where a patient has been taking treatment for his diabetes and taking almost 100 units of insulin along with having a weight in the range of around 100 to 110 kgs, what should be our focus? Treating his diabetes or treating his obesity is a question we will all have to answer. If you ask me, obesity is a mother of all medical comorbidities, and unless we focus on the root cause, correction of the effects is going to be difficult. So here is an example who has undergone laparoscopic Roux-en-Y gastric bypass, and he is off all his diabetic medications purely because we tried to focus on his root cause, the obesity, than only focusing on his medical illnesses. And we do come across lot of patients in our day-to-day practice where surgeons and all the clinicians have to justify our options of treatment. And many a times patients' story when they gain weight is that they are not willing to do anything from their side, and it is the clinicians who have to advise them the treatment options. And probably this is my earnest request to all of us over here, that as a clinicians, as a family physicians, as physicians, when all our current medical management options are not effective, we should do enlighten them about interventional options of treating obesity and metabolic syndrome. This is a routine story of patients that when it goes to a exercise expert and he has excess weight, the exercise expert will push him to lot of weight training. If the patient goes to a dietitian, the dietitian will put him or her through a diet regime. If a patient goes to a particular specialist, we tend to look at the patient from that particular ailment only. Whereas we feel that when we are looking at patient, we should look at a patient as a whole, and that is why these kind of conferences really create an impact, because here we are understanding all the possible options which we have when it comes to treating our obese patients having metabolic syndrome. There are some important concerns when it comes to non-surgical options of obesity and metabolic syndrome. A typical weight loss in dietary and lifestyle modification program in patients who have severe obesity is only around 1 to 3 kg per meter square in comparison to almost 13.5 kgs per meter square after interventional procedure. The attrition rate, the compliance for non-surgical options decreases over a period of time, and dietary programs and lifestyle programs have a high attrition rate despite these therapies being effective or successful for patients. But many individuals, their obesity does not get resolved, and the extent of weight loss is relatively less compared to their overall BMI. Also important concern is not only the science of weight loss, but to maintain the lost weight. We know that a lot of patients undergo a lot of regimes of weight loss, but the challenge is maintaining the lost weight. And the success rate of 129 centers in the world specialized in outpatient obesity care in treating patients with obesity by medical line of management is just 7% after 24 months. So here is my earnest request to all the clinicians who are attending this conference to take the self-doubt out of their mind. What if is not a choice. Fear of obesity surgery, if it is with us as clinicians, we won't be able to give this option to our patients convincingly. Obesity surgery is in vogue in India since 2000 and world over since 1998. There are enough number of patients who have undergone this surgery for more than 20 years and are living a life very healthy. So here is my question to all of us here. How would we manage this patient who is 40 years old, having a BMI of 40, known diabetic and hypertensive, and not responding to our current medical line of management? Can only medical and lifestyle measures will suffice? And the answer probably is definitely a big no. So here I am sharing what are the recent changes which have happened in the trends of interventional options in weight loss and in bariatric surgery. So understanding of surgical efficiency for weight loss has changed immensely. Earlier it was more focused about losing excess weight, but now the focus has been equally in treating overall metabolic syndrome. So it is no longer only for weight loss, but it is equally also for treating the overall metabolic syndrome. We should not debate whether a restrictive surgery will work, whether a malabsorptive surgery will work, because each patient is different and each patient should have only one surgery as an option to him. So probably we should focus on constructive outcome which is better for our patients. Well, the trend is changing. These days we are favoring more and more reversible bariatric procedures compared to non-reversible bariatric procedures, so that we still have an option of going back to the original anatomy if the need arises, thus reducing the long-term challenges after bariatric surgery. And yes, probably the biggest change in the trend is acceptance not only from the medical fraternity but from the governance, acceptance from the insurance, and more patients are getting covered in their insurance when it comes to treating them for their bariatric surgery. Yes, and also we as bariatric surgeons have started accepting that surgery is not only the way of treating obesity and metabolic syndrome. Surgery followed by continuous diet and exercise along with lifestyle modifications are necessary. So it is no longer me but necessarily we which is going to play a role. Thus friends, we all know when other treatment options for severe obesity are unsuccessful, it is prudent to consider use of interventional options for weight loss like bariatric surgery within the context of existing guidance. So what are the options? Gastric balloon, sleeve surgery, gastric bypass, one anastomosis gastric bypass, and different newer bariatric surgeries. Here I would love to quote of my teacher with whom I spent training of my bariatric surgery, and he always used to say, help as many patients once and let that surgical option be the only or the last option for your patients instead of doing multiple surgeries or redos for a patient. Endoscopic gastric balloon. An inflatable silicone balloon is placed inside the stomach either by means of gastroscopy or a fluoro guidance under anesthesia, and this balloon is inflated to the capacity of around 300 to 500 ml. This is a purely daycare procedure and it's completely reversible because this balloon is removed after a period of 6 months to 1 year. This is the image depiction of a gastric balloon. Gastric balloon basically decreases the gastric emptying, and it needs diet and exercise along with its mode of action. Outcome: weight loss in the range of around 15 to 20 kgs at the end of 6 months to 1 year can be easily achieved with gastric balloon. Success do require a highly motivated patient because balloon needs diet and exercise along with it for good weight loss. Common side effect of gastric balloon in the initial period is nausea and spasmodic abdominal cramps, and patients need to be made aware about these challenges. Once they cope up with these initial challenges, it's very good acceptance and very good outcome. Sleeve gastrectomy is a procedure which is performed laparoscopically, where 80% of the excess stomach is removed from the body, and this leads to secreting of ghrelin hormone. The only downside of sleeve gastrectomy probably is that it's an irreversible procedure. Usually it is preferred in patients who are elderly or who are highly comorbid, so that it can be quick in, quick out procedure. Standard contraindications for sleeve gastrectomy include a hiatus hernia and a gastroesophageal reflux disease. So preoperative gastroscopy is mandatory before subjecting a patient for sleeve gastrectomy. Gastric bypass. Roux-en-Y gastric bypass is a procedure which is in vogue since last almost 35 to 40 years. It is supposed to be the most gold standard procedure for metabolic syndrome, and the biggest advantage is that it's a reversible procedure. Indications include metabolic syndrome, and usually patients who are having metabolic syndrome, they need additional procedures to have effective weight loss and resolution of their comorbidities. Contraindications include cirrhotic patients and smokers, because cirrhotic patients cannot tolerate some element of malnutrition and their cirrhosis can get worsened. Smokers can lead to stomal ulcers, and that is why it is a complete no-no when it comes to bypass. Single anastomosis gastric bypass or a mini gastric bypass is a new procedure which has been there in use for last 5 to 8 years with very effective weight loss. The most important precondition is that patients should be a non-vegetarian patient, because their protein demand after surgery is to the tune of 80 to 100 grams of protein per day. Indications for mini gastric bypass include volume eater patients and super obese patients, and contraindications remain the same like any other bypass: a cirrhotic patient and a smoker. So to summarize, friends, bigger trend, bariatric surgery is going to be there as one of the treatment option when treating patients having excess weight with or without metabolic syndrome, and is one of the treatment options to be considered. Only lasting trend for all of us as clinicians is accepting this and adopting to the current generation of practice. I don't want to be generic, or I don't want to be claiming that bariatric surgery can be administered easily without complications and induces appreciable weight loss with statistically significant reduction in BMI and improvement associated with comorbidities. We need to be case specific and patient specific. It is all about our outlook. What looks evil also can be good if our outlook towards the situation is different. Let's not be in conflicting positions, and let's be helping each other for betterment of our patients. Thank you so much.